Thank you so much, sir. So, as soon as we see a case like this, a true post-polar cataract which has a nearing appearance like this, we know that we are on a deadly ground. And there's a high chances of opening up the posterior capsule in these kind of true post-polar cataract. So we always have to be careful at each and every step. So let's see what all is needed to be done. So coming to the sizing of capsular axis, you know that size should not be more than 4.75 or 5 millimeter, because in case there is a big PCR and you're not able to put a single piece IOL in capsular bag, you may need to put a 3-piece IOL in sulcus and do optic capture. And for that optic capture, you need a rexis which is not more than 4.75 millimeters. We always avoid cortical cleaving hydrodissection, just hydrodelineation to delineate the endonucleus. And once you do that, you just go ahead and try to chop the nucleus. And once you chop and divide this nucleus, don't do much of the lateral separation. So our idea is never to put a pressure on the posterior capsule, just do little separation and turn your bevel to one side, chop this nucleus in like a piece of cake and take this out, turn it bevel on other side and take this nucleus. And by the time you do this, most of the time this endonucleus becomes mobile and you can take off this endonucleus, and what remains is, so essentially it's the layer by layer separation what we are doing as taught by Dr. Tityal sir also. So we just loosen up the entire epinucleus, try to loosen it up, and always maintain closed chamber. That should be the goal, because that's the key to success in these kind of cases. So once you loosen up the epinucleus and then you take this epinucleus, so we are coming to the last portion there. So this is the, so our idea is to try to delay and prevent the opening of posterior capsule as much as possible. So this is the last epinuclear sheet which is coming up, and once this central plaque comes off, I see that there is a PCR there. So maintain closed chamber. Just if you see the movements of posterior capsule like this, it's opening up, you know that there is of course a vitreous there. It indicates. So you just take off your chopper and put viscoelastic from side port before stopping your infusion and taking out this. Now our aim is to clear the entire anterior chamber from the vitreous, because unless and until we remove the vitreous from anterior chamber, we can't take off this cortical matter which is there. So I go ahead and stain with triamcinolone and do 2-port anterior vitrectomy. So once you finish off anterior vitrectomy and clear off entire vitreous from this anterior chamber and capsular bag, then you can take this cortical matter. Remember that PCR and vitreous coming out, the complications only occur when we don't manage them properly, and we don't have to put any traction on the vitreous, because that will give traction on vitreous base and that will cause long-term complication. So again, I'm maintaining anterior chamber before turning off irrigation, and now the entire vitreous is clear. So either you can use the same cutter on IA cut mode, or here I'm using bimanual IA. So you see, you can only strip this when there is no vitreous. So take off the cortical matter there. You can see there is a big PCR extending from this side to other pole. Again, before changing my hands, I'm maintaining closed chamber, putting viscoelastic. And then you change your hands and very meticulously you clean up the entire capsular bag. and these are the last pieces of cortical matter which you take out. And keep your irrigation cannula towards angles, not directing posteriorly. So again, maintain chamber, and this is a 3-piece IOL which was in the backup for this case. So once you load this 3-piece IOL, it's a little tricky to implant these lenses because haptic tend to come out in a funny way many times. So loading of the lens, so a small trick for that is just pay attention to the haptic, that it should always come out horizontally beneath the iris. So always try to keep it horizontal and then turn your wrist in anti-clockwise direction so that haptic doesn't point it downwards. And then you put this IOL in sulcus, and after putting this, use Q-lens hook to capture this optic. So again, go ahead and put some visco over top of the IOL and use Q-lens hook to capture on one side, and then you can capture it on other side. So this is anti-optic capture. So rexes become like a shape of a rugby football. You can check on both the sides. So this capturing is needed for long-term stability of the IOL in the sulcus. So that's where the importance of sizing of rexes comes. And put some Miocol, and you just hydro stitch all the incision. So this finishes the case, and I'll just show you the post-op photograph. You can see a through and through tear here, but the lens is nicely captured in the sulcus, and it's very well stabilized. See, another case, what I want to show here is that every PCR doesn't mean there is, okay, fine. Yeah, I think I'll stop it here only. Thank you so much for this wonderful opportunity.
Just a quick comment. Nowadays, we have made it a practice to do a OCT-based ASOCT, and we are quite surprised. We have done 49 eyes in the last 3 months or so. The number of eyes where the posterior capsule is completely intact. In those cases, we just go ahead and use it, do it like a routine cataract surgery. Yes. And it saves a lot of time, you know, a lot of, it's much more controlled. We find that this sign has a very high negative correlation, in the sense that if the PC is intact on your ASOCT, then very unlikely that you will have a PC defect. Of course, it might be thin, so more careful measures, but you can handle it like a routine surgery.
Yeah, but you should always follow the principle. Even if OCT tell, because PC will be thin, I'm talking of true posterior polar like this.
No.
We
have come across about 5 eyes where there is a posterior capsular defect. In that we did all that we showed. Another observation is that, you know, usually in the posterior polar cataract, the runoff of the rexes is from pole to, the PCR is from pole to pole. Yeah. So usually you have 2 flaps of posterior capsule intact. So whether it's a toric intraocular lens or a multifocal lens, very carefully you are able to insinuate them in the support that is available, because none of these lenses come in a 3-piece platform. I'm sure you would have done it.